This is Mitchel Zoler reporting for Global Medical News Network.
We saw in patients that were treated based on a symptom onset that was unwitnessed, they had a lower risk of bleeding in the brain as a result of the TPA than people with a known duration of symptoms, people that actually had a witnessed symptom onset.
And so the implications for practice that you draw from this finding?
Well, actually, they're twofold. The first is that common sense would dictate that people with an unwitnessed symptom onset are likely better candidates, because only in the worst case scenario would their symptoms have lasted for as long as they were last seen well. But over and above common sense, we now know from the work that we did that they are truly at a lower risk of hemorrhage in the brain, and therefore they are better candidates to treat than people with a witnessed symptom onset.
Mm-hmm. And so the way this translates to practice, given that there's a typical door-to-needle time of approximately 60 minutes, if a patient comes in who was last seen normal within the prior 3.5 hours, any of those patients would be reasonable candidates to receive TPA?
Oh, I believe so, yeah. So if someone makes it through the doors of a hospital with an hour to go in the 4.5 hour time window, we have evidence from the ECAS-3 trial and other evidence, and there is guidelines that suggest that patients should be treated even with a known duration of symptoms of 3.5 hours. But over and above that, if they were simply discovered an hour ago, but last seen normal 3.5 hours ago, they're actually better candidates even than the patients that were enrolled in ECAS-3, because many of these patients will likely have symptoms that were only an hour or two in duration, and that's reflected in the lower hemorrhage rate.
Right.
For Global Medical News Network, this is Mitchel Zoler.